Now, to tell you a little bit about leakage, when in non-invasive, because you have this leakage occurring, the ventilator has, I call it, peak demand flow. So in other words, if the mask is on and I pull, I can get up to 200 liters per minute of flow. The ventilator knows, and it will deliver, and it will compensate me for that, which is far more flow than any other V60 or any other ventilator can deliver. So your likelihood of satisfying patients' demands are much greater with the servo and non-invasive. So when I pull, I can get that much flow. However, the ventilator now has also a leakage flow that it has to deal with. So the leakage flow, you see on the very bottom right-hand side above additional values, it says leakage 1% or 2%. That's basically because I have no leakage because I'm connected to this rather than a mask, right? But if I did have a leak, the ventilator now, notice when I created the leak, the ventilator is beginning to auto-cycle a little bit, right? After a few auto-cycle breaths, the ventilator stops auto-cycling. Because what it's done is it's learned the new base flow and it's adjusted its inspiratory or its sensitivity, okay? So if it leaks a little bit more, it'll auto-cycle again, and now our leakage now is 72%, okay? Then the leak seals up, and now the sensitivity changes, and now the leak percentage will go down. As that leak occurs, the ventilator will deliver up to 65 liters per minute of flow to try to maintain the settings that we have set. If the leakage flow, in other words, the mask goes up here, you know, or up on his forehead, exceeds 65 liters per minute of flow, you're going to get this. The ventilator goes into a pause or suspended state. So see where it stopped over there and the waveform is coming around again? When it connects, when it comes around once, you're going to get this alarm that says leakage out of range. Leakage too high, constant flow delivered. Now that constant flow that's coming out of here is 7.5 liters per minute. Okay? So the ventilator is saying, hey, what's happened is that the leak got so big that I can really no longer effectively ventilate this patient, and I want you to come over and check this patient out. So you come over and the mask is over here, it's on his ear, it's on his eye. So you go, come on, Jim, you gotta keep this mask on. So once you reset the mask, the ventilator will detect that and it will begin ventilating again. This message will be there for another couple of breaths and then go away by itself, and you do not have to hit the resume ventilation button. If you want to, you can, but the alarm will still be there. It just happened to go away when I hit the alarm. It would still be there for another breath or two and then go away by itself, or you can silence the alarm. So that's your excessive leakage alarm that occurs. Okay? So sometimes that created problems. They go, why am I getting this? Why does it go to this pause state? Well, it's because you're not effectively ventilating. Now some people say, well, if the mask does come off, I would still like the ventilator to so the patient can get some wafting of O2. But the problem is, and we can make the ventilator do that if you want, there's a setting that I can set to do that, but the problem is if the mask is here and it's you're blowing 65 liters per minute of gas into the patient's eye, and which might not be a good thing. So that's why the ventilator goes to pause. But there is a way to say we want to disable that function, and it will just keep blowing and alarming and blowing and alarming, just like a V60 or another type of ventilator would, I believe. I'm not real sure about that. But some of the other ventilators will just keep blowing. And then when you do this, then it'll stop. Okay? So there's a way to do that if you so desire. So that's how your leakage flow works, and that's how your triggering works. So the only other thing to explain is saying, okay, let's say that this patient is breathing and triggering the ventilator. Why do we want him on this mode? Let's go to non-invasive pressure support, where the patient has a spontaneous effort, and we can set an IPAP and an EPAP if that's the way you want to term it. So when we go to non-invasive pressure support, we still have the pressure support and the PEEP and the FiO2, but now we have this inspiratory cycle off. Whenever you're in a mandatory, like pressure control or volume control, you always have an I time that tells the ventilator when to start the breath and when to end the breath. Let's say you set a second I time. But in a support mode, like pressure support, the ventilator has no time. There is no time associated with the delivery of that pressure support breath. So consequently, the ventilator still has to have a way to terminate its breath when you're in that spontaneous breath. So if you're in INV pressure control, pressure support, the mandatory breaths are maintained by that I time. But then when they take a pressure support breath, how does the ventilator know when to turn itself off, right? So you trigger the breath on, and you get 10 centimeters of support, but how does it know when to turn off so that you can exhale? Well, the way that works is that and this is essentially the same in all ventilators, when we breathe, we start at zero flow. We breathe into some peak flow as we breathe in, and as our lungs fill, flow slows down, and just for an instant, before we go to exhalation, our flow is at zero flow, and then we exhale again. So it looks like that, right? So what inspiratory cycle off is, when you're in a pressure support mode, what this parameter is right here, is it says, the ventilator says, all right, well, if there's no time, to tell me when to turn off, I'll turn off based on the diminishment of flow, or the slowing of flow as the patient breathes in. So if we set the inspiratory cycle off at, say, 50%, what the ventilator will do is it will say, all right, I'm going to mark whatever that peak flow is. I'm going to measure it. It won't tell you what it is, but it'll measure it. And because they told me to cycle off when the inspiratory flow gets to be 50% of whatever the peak flow was, so let's say the peak flow was 50 liters per minute. When the flow diminishes to 25 or 50% of that, which is 50% of 50 liters per minute is 25 liters per minute. Let's say this is, this was 50, so this is 25. The ventilator then goes to exhalation. So this point here, 25 liters per minute, which is 50% of the peak flow. So if we set our inspiratory cycle off at 70%, the ventilator would cycle off here. If we set it at 30%, the ventilator would cycle off there. So in theory, the way we breathe, we want to breathe until we're full, right? And when we're full, flow stops. So in theory, we would like the inspiratory cycle off to be set at 0% of peak flow. So we can bring it down to 1%, but I would rather have it on 5% to account for any leakage, because in the event that we had a leak now, we breathe in and flow just keeps going like that because you have the inspiratory cycle off set at 30%, but because the flow never got to that point, the ventilator just keeps delivering flow. So on a patient whose cuff is collapsed or whatever, he breathes in and he goes, hey, turn this ventilator off, what's going on? Because the ventilator keeps delivering the flow and the flow's coming out through the cords and he can still talk to you, right? So if you can't put any more air in the cuff, what you could do is say, all right, Mr. Smith, what I'm going to do is I'm going to set your cycle off point up higher so that, hey, it cycles off much sooner, okay? So the point of this is that you can tell the ventilator to compensate for leakage that might be occurring depending on where this is set. And the other reasons that you can use inspiratory cycle off is to make, if you had a patient that was breathing very fast and his inspiratory cycle off was set at 50% in pressure support, just in pressure support, and he's breathing fast, it means he's getting cut off too soon, but maybe he wants to take a longer breath, which would mean more volume that he gets. So if you increase or decrease your cycle off point down to 20% or 15%, he can take a longer breath. Now on the other hand, if it's like a baby or an adult that is breathing very fast, and because he's fast, when he exhales, he's got auto peak because he's not allowing enough time for exhalation, you can say, well, I'm going to terminate his breath sooner so he can exhale longer to get rid of that auto peak. So you could use it that way as well. So there's various ways that you can use this particular feature, the inspiratory cycle off. But in non-invasive, just talking about leakage, it's set higher to help you compensate for the leak that you might occur, so the ventilator goes up and terminates sooner. But now this patient that's apprehensive, you set your upper pressure limit at 30, you set your inspiratory rise at 30, but this is still set at 50, so it's cycling off sooner than he would like it to, and he's thinking, they are trying to suffocate me, they're not allowing me to take a nice deep breath, so they get a little agitated. So if you set this at 30, hence my little saying, when you're in non-invasive, go 30, 30, 30. This is the last 30. You know, the inspiratory cycle off is 30, and then the upper pressure limit would be at 30, and then your inspiratory rise would be at 30 as well. So here we have inspiratory rise when we're in pressure support here. So we set this at 30, and we have our upper pressure limit set at 30. We're good to go. So the last thing to tell you about non-invasive is the backup when you're in pressure support, and we have the ability to go to backup ventilation, in which case if he is and he stops breathing, you know, you still have the mask on, you say, well, I'm going to set a pressure control of 15, a rate of 15, and an I time of 1 second. So then if he does stop breathing in pressure support, so he's breathing away, can you see that 30% point on the flow waveform? So somebody could say, well, what's that point where it drops down? You can say, well, that's 30% of the peak flow. And you go, how do you know that? You say, well, just because I'm a genius. But so this is your peak flow, and that's 30% of whatever that number was. So if he has a leak, a big leak, the flow never gets to that 30% point. There's a secondary cutoff point, which is I time, and so the ventilator will go for 2.5 seconds and then go to exhalation. That's secondary, but by that time your patient is a little agitated because he's getting blown at for 2.5 seconds, right? That if we have this where we are breathing, and then we have this apnea. In non-invasive, you will have an apnea delay. So if we set that at some reasonable number, if the patient doesn't take a breath for 20 seconds, you may get a minute volume alarm, you may get a rate alarm or whatever. After 20 seconds, you're going to get an alarm that says, no patient effort. And now the ventilator goes into, and see there's the rate, your respiratory rate. And now if he wakes up and starts breathing again, he resets it, okay? Then if he stops, it'll go back, and he can do this all the time. He can keep doing this, go back and forth, apnea versus not apnea, back and forth when you're in, and there'll be no limit to the amount of time that he can do this. If you are in invasive pressure support, and the patient had apnea like this, same way, but he's just in invasive, and then he starts breathing again, the ventilator will allow this to happen 3 times within 2 minutes. So if you put him in pressure support, plain pressure, no INV, just pressure support, and he has an apnea period 3 times within the first 2 minutes, after the 3rd time, in other words, the 4th time he has apnea, you're going to see a box come up that says, I'm going to lock him out and keep him in backup, because if he's had 3 apneas within 2 minutes, you may want to reconsider your strategy. But if he has an apnea now, and then another one in 10 minutes, another one in another 10 minutes, he could do that all day in invasive. It's just that if it's within 2 minutes in invasive, then you're going to get locked out. He'll remain in backup, and you have to manipulate the ventilator. Here, he can have 3 apneas within 2 minutes, and it doesn't matter. He'll just keep going back and forth.